We are live now, Doctor.
Okay. Good afternoon, everyone. So today we are again coming back with YOSI iROCK, another session. This is Prelims Session 4. Today's subspecialty is Pediatric Ophthalmology, Neuro-Ophthalmology, and Squint. We have 4 esteemed judges with us today. Dr. Prachi ma'am, Dr. Kavita Porwal, Dr. Sovita Rathi ma'am, and Dr. Sumita Muthu ma'am. So today's session will be moderated by Dr. Nupur Goel ma'am, Dr. Harshal, and me, Dr. Moshmi Banerjee. So today we have 5 teams with us with very unique names of Team Macular Goals, Avengers, Optic Avengers, Team RRR, and Team Annulars of Wen. So I'll play the video of our YOSI iROCK. So this is our governing council for YOSI team 2024 to 2026, and it is headed by Dr. Divakan Mishra sir, who is the president of YOSI. This is the executive council, which comprises of very dynamic young ophthalmologists. So these are all the curriculums which are being performed by YOSI currently, and everybody is invited to participate in all of these activities. So this is the team YOSI iROCK core committee. This is the special logo of YOSI iROCK, which is created by Dr. Samir, who is also a member of the YOSI iROCK. So these are the previous sessions which has already been conducted by YOSI iROCK. Session 1 was on oculoplasty, session 2 on glaucoma, and session 3 on cataract. So Team YOSI is excited to announce YOSI iROCK, and registrations are still open till 15th of March 2025. We are hoping for more registrations. So let's come to the rules of today. So each team will have 3 members, and only junior residents are allowed for YOSI iROCK. Top 2 teams from each prelims will go for further rounds. We will take 7 finalist teams, and YOSI iROCKsters for YOSICon will compete physically at YOSICon, which will be conducted in New Delhi from 5th to 7th of September. And they will also be awarded with travel grants for YOSICon. Top 3 teams in grand finale of YOSICon will be awarded travel grants and will be titled YOSI iROCK Superstars. So there will be 4 rounds today. Round 1 will be seminar presentation, which will be judged by our esteemed judges. Round 2 will be on a creative round, where there will be creative videos which will be shared by the participants. Round 3 will be comprising of certain quizzes, and round 4 will be unscrambled words. So so audience prizes are also there. So audiences, we are hoping that you guys also join today. So our first judge today is Dr. Prachi ma'am. She is a consultant pediatric ophthalmologist, squint specialist, and neuro-ophthalmologist, and she is a director, medical director of Akasha Hospital, Mumbai. She is a consultant pediatric ophthalmologist at Dr. Agarwal's Advanced Eye Hospital and Institute. She has done her fellowship in pediatric ophthalmology from Arvind Eye Hospital, and also a fellowship in retinopathy of prematurity from LVPI Hyderabad, and observership in nystagmus treatment from USA. She has multiple publications in national and international journals, as well as book chapters. She has been awarded Best Paper Award at Bombay Ophthalmology Association Conference in 2017, and also awarded the Gold Medal for Best Paper and Best Case Presentation at Strabismus and Pediatric Ophthalmological Society in 2018. So welcome, ma'am. We are happy that you could join today. Our next esteemed judge is Dr. Kavita Porwal, ma'am. She has done her MS Ophthalmology from Gajra Raja Medical College, Gwalior. She has also had a certificate course in pediatric ophthalmology and strabismus from Sangli, and short-term training in pediatric ophthalmology and strabismus from M&J Regional Institute of Ophthalmology, Ahmedabad. She is also a recipient of many international and national awards. Few of them are Professor Kamlesh Gold Medal for Best Presentation in Free Paper Session, both in 2016 as well as 2017. She has also been awarded the AIOS Physical Poster Award in Comprehensive Ophthalmology in 2024. She also has multiple publications in national and international journals. So, welcome you, ma'am, for participating in today's session. Our third judge is Dr. Sumita Muthu ma'am. She is currently a senior pediatric ophthalmologist at Narayana Nethralaya and heads the myopic clinic at the Narayana Nethralaya, Rajaji Nagar. She is a fellow of Royal College of Physicians and Surgeons of Glasgow and Edinburgh. She has multiple achievements and awards. Few of them are Best Paper in Young Ophthalmologist category in American Academy of Pediatric Ophthalmology, Best Paper of Session Award in Neuro-Ophthalmology in AIOC 2019, Best Poster Award in Neuro-Ophthalmology at AIOC 2020, and E.T. Selvam Best Poster Award at AIOC 2020. So welcome you, ma'am. Our next judge today is Dr. Sobita Rath, ma'am. She works with Dr. Shroff's Charity Eye Hospital as a consultant in the Department of Pediatric Ophthalmology, Strabismus and Neuro-Ophthalmology. She is an alumni of prestigious L.V. Prasad Eye Institute. Her areas of interest includes optic neuropathies, oculomotility disorders, and complex strabismus. She is also actively involved in the various teaching and training programs at HCEH. She also takes care of the neuro-ophthalmology services there, and she has various publications and awards to her credit. So welcome you, ma'am, for today's session. So I'll invite Dr. Harshal to please introduce the moderators and the participants.
Good afternoon, everyone. I would like to introduce our first mentor, Dr. Dr. Nupur Goel, ma'am. As you all know, she is like the whole concept of this YOSI, iROCK is like given by Dr. Divakan Mishra sir, but the execution part is, and you can say the heart and soul of this YOSI iROCK is Dr. Nupur Goel, ma'am. Welcome, ma'am. Ma'am has completed her long-term fellowship in comprehensive and oculoplasty from L.V. Prasad Eye Institute, Hyderabad, and currently working as a consultant in anterior segment and oculoplasty at Eye Care Eye Hospital and PG Institute at Noida. She has keen interest in academics and teaching, as you all know. And she was a UC executive member 2020 to 24. Right now she is a NOS Times editor, UC socioculture team leader, and UC iROCK team leader, and she is a managing editor of Yo Times. Thank you, ma'am. Next mentor is Dr. Mosimi Banerjee, ma'am. As you all know, she has already completed her MBBS from KGKar Medical College, Kolkata, West Bengal. Along with that, from the MD, she has finished from prestigious RP Center, AIMS, New Delhi. Ma'am has completed senior residency in phaco refractive retina uvea and ROP services from RP Center, AIMS, New Delhi. Ma'am is right now assistant professor at Maharaja Agreshan Medical College, Haryana. Madam has more than 60 publications in peer-reviewed journals and have presented at many national and international conferences. Ma'am has awarded Best Paper of the Session at Neuro-Ophthalmology at AIOS 2020, and she is the winner of Free Paper Session in Comprehensive Ophthalmology Session in SAO 2023. Ma'am got second position in APO Imaging Contest 2024-25, and she has already got International Travel Grant and SCRB Travel Grant 2019, and Professor Yusuf Tano Travel Grant APVRS 2024. This is me, Dr. Harshal. I am a consultant in vitro retina UV and ROP at Dr. Agrawal Eye Hospital. I have done my MBBS from GMC Nagpur and MS from Nair Hospital, Mumbai. I have done my fellowship in vitro retina and ROP at Shankar Eye Hospital, Shimoga, India, and observership in ocular oncology, Murfitts Eye Hospital, London. I have around 32 publications in peer-reviewed national and international journals, along with one book chapter on sarcoidosis and reviewer of national and international journal. I would like to introduce our today's participants. Team 1, that is Macular Gold, with a captain Dr. Smriti Soni Tambi and Dr. Arvind Krishnan and Dr. Priyanka from Arvind Eye Hospital, Madurai. Team 2 is Eye Avengers from Arvind Eye Hospital with a team leader, team captain is Dr. Saundarya S, Dr. Karishma P. Reddy, and Dr. Mansa Bipiata. Our third team is, next. Third team is Optic Avenger from KGMU with the captain Dr. Shubham Agrawal, Dr. Ashdeep Karthik, and Dr. Medha Rai. Our fourth team, ma'am, next is from RIO Sitapur, that is RRR, with a captain Dr. Ravish Bindal, Dr. Anubhuti Bhargava, and Dr. Rahul Shukla. And our last team is from fifth team, that is Anulas of Wind, with a captain Dr. Hiba Abdul Rauf, Dr. Haifa Abdul Jalil, and Dr. Shruti Ji. I would like to introduce our dynamic president, Dr. Divekant Mishra, sir, to address our session. Sir, you are welcome. Can you just say a few words about this session?
Thank you so much, Dr. Harshal. And first of all, I would like to acknowledge our judges who have taken out time from their busy schedules. Dr. Dr. Prachi ma'am, Dr. Kavita ma'am, Dr. Sovita madam, and Dr. Sumita madam for taking out time for this important session. And a big shout out to the team. I'm part of all the groups, and I see the stress that they go through every time they organize a session. So it's a lot of hard work that goes behind. It's not just these couple of hours that the work happens. It's so much of work, and only this team could have been able to pull it off the way they are doing it. So a big shout out to them. And let's move on and start with the session. Best of luck to all the wonderful teams. And it takes a lot of courage to, come up and participate on national level in such a competition. So best of luck to all the teams. Thank you. Over to you guys. Yeah.
Thank you, sir, for your inspiring words. So, a brief of the session proceedings. So, the first round will have the seminar presentation. The rules for round one are one member from the team will present on the following pre-decided topic. The presentation time will be 5 minutes and negative marking will be there if they exceed the limits. There will be a question and answer rounds after the presentation for 2 minutes. The total round comprises of 20 marks, and today's topic will be on pediatric ophthalmology, squint, and neuro-ophthalmology. So, round one, we are starting with Team 1 macular goals. Please share your video.
The second, Dr. Maushmi. So we have also, requested mentors from our teams to join and say a few words of encouragement. And if the mentors join, they have extra 5 points which they get. So from Team RRR, we have 3 mentors joining, and we'll just take their comments since they may have to, go for some other commitments. So we have the mentors from RRR, Dr. Yashveer Singh, Dr. Sirohi sir, and Dr. Shrikant Vaikar, sir. So over to you, sirs, if you can just say a few words. Dr. Shrikant, sir, and Dr. Yashveer Singh, yes, sir.
I am Professor Yashveer Singh Sirohi, and from RIO Sitapur. I wish all the best to my team, comprising Ravish Bindal, Anubhuti, and Rahul, and I know they will do very well.
Thank you, sir. Thank you for joining and giving those words of encouragement. Dr. Shrikant Vaikar, sir, yeah.
Yeah, I'm Professor Colonel Shrikant Vaikar, and it's an excellent initiative from YOSI. I must compliment you all for this. And I wish my team the very best, Ravish Bindal, Anubhuti, and Rahul Shukla. I'm sure they'll perform well. All the best to you all.
Thank you,
Thank
sir.
you so much, sir.
Thank you, sir. We'll request the third mentor from the team, Dr. Sirohi, sir, if you're there to say a few words of encouragement to the team. Dr. Sirohi, sir, is there. Dr.
I already wished them.
Sorry, sir.
Once again, wish them all the best.
Yeah, thank you, sir. Thank you, sir. That's my thing. Yeah. So I think with this, we can move on to our seminar presentation. Over to you, Dr. Maushmi. Yes.
Yes. Ma'am, I think Team Macular Goals mentors have also joined and they also want to share a few
Sure.
words.
So we can just have them and then they can present their.
Dr. Kaushalya, ma'am, welcome you, ma'am. Ma'am, you are on mute.
Good morning. I congratulate my team and I wish them all the best for a successful presentation. Thank you.
Dr. Anthony, sir, if you are there.
Am I audible?
Yes, sir, you are.
Yeah, I congratulate my team and I wish them all the very best. And I congratulate YOSI for these innovative methods by which they make science fun.
Thank you.
Thank you, sir. We have also the mentor of Team Optic Avengers, Dr. Rajat Mohan, joining us. So if you could just unmute yourself.
Yeah, hi. Another great initiative by UC. So, best of luck and best of luck to all the participants. To Team KGMU, I would like to say you guys are great, and I'm sure with so much of things going in the background in all of your personal life, you have come together to give this presentation. I'm more than happy that you're presenting it, and I'm very sure that you're going to do great in this. So, best of luck and do well.
Thank you. We thank you, Dr. Rajat Mohan. We also have the mentor of Team Annulus of Wind, Dr. Rajni Nair, ma'am. Ma'am, if you can just unmute yourself and give a few words of encouragement to your team.
My team comprises of Dr. Hida and Dr. Shruti and Haifa, and I'm sure they will do an excellent job. And congratulations to YOSI also for conducting such a wonderful, successful program.
Thank you, ma'am. Dr. Harshal, can you invite the mentors of Team iAvengers to...
Yeah, Dr. Sharmila ma'am and Dr. Mahesh Kumar sir.
Hello, good afternoon to everybody. I thank the YOSI for creating this platform for the postgraduates to showcase their talents. And I congratulate all the team members for their active participation and wish them very happy and good luck. Learning is a process, continuous process, and I think participation is the key. I wish all the participants a very happy presentation. Thank you.
Thank you, ma'am.
I wish my team members, Charishma, Manasa, and Soundarya, all the very best. They've done lots of hard work for this, and I'm sure they will do very well. Best wishes to them. Thank you.
Thank you so much, sir.
So thank you all the mentors for joining today. So we'll start with Team 1 Macular Goals. Please share your presentation for the first round.
Yes, ma'am. Is the presentation visible, ma'am?
Yes.
Yes.
Shall I start, ma'am?
Let me start the timer. 1 minute.
Yes, ma'am. Yes, sir. Yes, sir.
Yeah, you can start.
Good afternoon, everyone. We, the team Macular Goals, are here to present to you about Duane's retraction syndrome. It is a type of congenital cranial disinnervation which is characterized by limited horizontal ductions, narrowing of palpebral apertures, and possible upshoots and downshoots on attempted abduction or adduction. The disease is thought to result from an injury to the developing embryo between 4 to 8 weeks, causing aplasia or hypoplasia of the 6th nerve nucleus and primary disinnervation as a result. This is followed by abnormal innervation of the lateral rectus by the oculomotor nerve, causing secondary disinnervation. Both horizontal recti contract during adduction, leading to globe retraction. Over time, non-innervated lateral rectus fibers become fibrotic, creating a tight lateral rectus, while fibrosis of other recti can cause persistent esotropia and overshoots. Duane syndrome often presents unilaterally. Bilateral Duane's occurs in 10% of cases, sometimes asymmetrically. It is typically sporadic and is associated with CHN1, HOXA1, SAL4 gene mutations. When it comes to clinical examinations, it is important to evaluate for refractive errors, the ocular movements to assess for abduction or adduction, and to measure the extent of deviations, if any, by using a prism cover test. Limitation of eye movements is usually abduction, which is more common than adduction, but can sometimes coexist. Globe retraction in adduction is caused by paradoxical innervation, causing co-contraction of the medial and lateral recti. Abnormal head posture aims to center, enlarge, and maintain binocular single vision and compensate for the duction deficit. Overshoots are due to the leash or the brittle effect due to the sudden slippage of tight lateral rectus on adduction. While the mechanical shoots are very abrupt, innervational shoots are a lot more gradual. Moving on to the myriad of classification systems, we shall mainly focus on the Huber's classification, which takes into consideration the electromyographical changes along with the affected extraocular movements. While Duane retraction syndrome type 1 is characterized by limited abduction, widening a palpable fixture on abduction with a normal adduction and head turn to the affected side, Duane's retraction type 2 is characterized by limited adduction and exotropia with frequent upshoots and downshoots on adduction with head turned towards the normal side. Duane's retraction type 3 is characterized by an orthophoric position with no head turn because there is equal limitation of both abduction and adduction. There are multiple ocular and systemic associations with DRS and multiple syndromic associations, which includes Goldenhar syndrome, the Okihoro syndrome, the Klippel-Feil anomalies, and when associated with perceptive deafness, Wildewang syndrome. The DDs can be congenital cranial nerve palsies, which is the congenital abducens nerve palsies, which presents with large angles of deviation with no palpable fissure changes. Infantile esotropia is a comitant strabismus, presenting early in life with no signs of globe retraction or overshoots. Mobius syndrome has multiple cranial nerve palsies mimicking DRS with mask-like facies. Pseudoduane's is characterized by limited abduction accompanied by pseudoptosis on attempted abduction. Initially, conservative management is attempted and refractive errors are corrected. Surgical interventions are indicated when there is significant deviation in primary gaze, compensatory head posture, overshoots, and severe retraction of palpable fissure. One would aim for a surgical outcome of eliminating compensatory abnormal head postures, reducing overshoots, and to improve overall ocular motility. In the case of esotropic Duane syndrome, ipsilateral or bilateral medial rectus recession can be attempted in unilateral cases with no co-contraction. In case of co-contraction, ipsilateral or bilateral medial rectus recession with lateral rectus recession can be attempted. In case of upshoots, a Y transposition can be attempted, which is shown as in the following picture. This is to avoid globe slippage. In the case of exotropic Duane syndrome, ipsilateral lateral rectus recession with Y transposition can be attempted if there is an upshoot defect. And in severe cases, we can go for a periosteal fixation of the lateral rectus. So to conclude, Duane syndrome is a long-known entity whose understanding keeps evolving. Each presentation is unique, and further management is always customized according to the patient. Thank you.
That was a very nice presentation, Team Macular Goals. So over to the judges for their comments and questions.
Team Macular Goals, you can stop sharing your screen. We can start with Dr. Prachi, ma'am. Yeah.
Ma'am, your voice.
Yeah, ma'am, you're on mute.
Yeah. So very nice comprehensive presentation in the limited time frame. So first question that I would like to ask is, can you name 3 other congenital cranial disinnervation disorders?
Go for Brown syndrome.
Okay.
Then we can go for congenital fibrosis of extraocular movements as well. So, ma'am.
Okay.
I'm not able to think of the third one, ma'am.
Do I ask the next question or the next judge asks the next question?
Ma'am, you can ask as many questions as you want.
Okay. Can you tell me the difference between a primary deviation and a secondary deviation?
Primary deviation, it happens in primary gaze itself. And ma'am, 1 minute, ma'am.
Ma'am, should I add the point? Can I help my teammate regarding?
Yeah, sure. You can go. You can.
Yes, ma'am. So a primary deviation occurs in the eye which is affected. That is the amount of deviation from the primary gaze. A secondary deviation is what is a compensatory deviation occurring in the other eye due to overaction.
Okay, good.
In restrictive strabismus, the secondary deviation will be more than primary deviation.
Thank you, ma'am. Dr. Sovita, ma'am, you want to ask questions, please?
Continue, very well presented. In a short time, you have covered everything. Continuing about primary and secondary deviation, where do you put the prism in which eye when you measure primary and in front of which eye when you measure secondary?
Ma'am, in front of the affected eye, we check the primary deviation. To check the secondary deviation, we should place it in front of the normal eye.
How do you distinguish between paralytic and restrictive?
Ma'am,
Differentiating.
yes, ma'am. There are like various, we can see the relationship between the limitation of movement and the ocular deviation. If it is proportional, it will be paralytic, ma'am. And it's not proportionally affected, it is in restrictive strabismus.
Very good.
Thank you, ma'am. Dr. Sumita, ma'am, your comments, please.
Yeah, excellent presentation and congratulations on the well-presented topic. So I would just like to ask two questions. One is what is the post-duction test which is done in Duane syndrome called?
It's called a Romero-Apis force degenerative test. So basically in that, we can ask the patient to look in a position that is between the normal gaze and adduction. So in that case, when the patient is in that particular position, at the temporal limbus, a force can be given to exacerbate adduction. In such a case, we might experience some restriction, which shows that there is some sort of restriction at the LR level. But when we ask the patient to attempt abduction, the patient looks a bit outwards, and at the temporal limbus, when force is given to exacerbate abduction, there will be a relaxation of the resistance will not be seen, ma'am.
Okay. And your next question is what are the indications of surgery in case of a Duane syndrome?
Duane syndrome,
For
ma'am.
example, okay, I will just come, okay, I will frame it differently. In case a patient with Duane's refraction syndrome comes to you with orthotropia, that is straight eyes in primary position, what other indications would there be for surgery?
First, we should evaluate for refractive errors. If refractive errors are corrected, then we should check if there is excessive overshoots, upshoots or downshoots. Upshoots or downshoots would be the primary reason as to why we would attempt surgical intervention in the case of orthophoric Duane's.
Anything else apart from this?
Ma'am, when the globe retraction is also too much, even though it is an orthophoric DRS, we attempt surgical correction.
Okay, excellent. Thank you.
Any cosmetic disfigurement due to abnormal head posture?
Yes.
Even if they're orthophoric, they might compensatory head posture might be there.
Yeah, usually they are, okay, I think we'll refrain from commenting. Yeah, okay, thank you.
Thank you, ma'am. We welcome Kavita ma'am also. She has joined a few minutes back. Ma'am, will you like to give some comments, please? Kavita ma'am, can you hear?
Yeah, I can listen.
Yes,
So
yes.
I was not there for the presentation, so I have not seen that. So maybe in the next one, we may put some inputs.
Sure, ma'am.
Okay.
Ma'am, we'll share the YouTube link with you, so you can just go back and see their presentation, mark them later on. Okay?
Yeah.
Yes, ma'am.
Yeah.
Okay. So, Team Macular Goals, you have really raised the bar high. So, congratulations. And now let's go to the next presentation by Team 2 iVentures. Please share your screen.
Team Avengers, are you ready?
Sir, just a second, sir. Is my screen visible, sir?
Yes.
Yes, sir. We'll start
Let
with
me
the timer.
start that. Yeah,
Yes, sir.
you can start.
Good afternoon. Today, I will be presenting nystagmus, an important clinical sign. Nystagmus is an involuntary repetitive movement that starts with a slow drift away from the visual target, followed by a corrective movement based on the nature of refixation. It can either be classified as fast if it is jerky or slow if it is pendular. Moving on to classification. Before we go into classification, let us speak about certain terminologies. A direction of gaze in which the intensity of nystagmus is minimized is the null point. Amplitude of jerk nystagmus is largest in the gaze of the direction of its component, as stated by Alexander Law. Angular distance traveled during nystagmus is amplitude. Number of to and fro movements per second is frequency. Eye movements allow eyes to closely follow the moving objects called pursuit. Quick simultaneous movements of both eyes in same direction is saccade. Conjugate nystagmus is symmetric in both direction and amplitude. When it is not symmetric, it is disconjugate nystagmus. Moving on to classification, we can either classify it as physiological or pathological. Physiological can be endpoint nystagmus, vestibular nystagmus, or optokinetic nystagmus. Pathologic can be further divided into sensory if vision is poor or motor. Further classification can be either congenital or acquired. A clinical approach, systemic diagnosing nystagmus, can be remembered with a mnemonic FDGR. Does nystagmus worsen or suppress with fixation? Is it horizontal, vertical, torsional, or is it always vertical? Is always central nystagmus. Gaze dependency. Does it change with gaze or direction, indicating MLF involvement? Periodic alternating nystagmus means brainstem disorders. The most important goal is to assess vision. When evaluating a patient with nystagmus, always test for binocular visual acuity first with the help of special charts such as ETDRS chart. If latent nystagmus is suspected, avoid monocular occlusion as it can exacerbate occulopsia. Instead, use a fogging lens technique. For refraction, retinoscope is more reliable. Soft contact lenses can also help in stabilizing the fixation. Others include prisms, tints, filters. Always assess for near vision separately and also color vision. Frontal goggles are used in diagnosis of nystagmus as they are incorporated with high dioptric lenses which help to see patients' eyes clearly by the examiner. Treatment of nystagmus is case specific and not all cases of nystagmus requires treatment. Optical aids include prisms, soft contact lenses. Pharmacologically, baclofen, gabapentin, clonazepam, memantine, and brinzolamide. Few surgeries include Kestenbaum-Anderson procedure and Faden operation. This is a video depicting opsoclonus where we can see involuntary eye movements in random direction. This is a case of internuclear ophthalmoplegia with dissociated nystagmus. We see a series of saccades followed by post-saccadic drift, which occurs when the patient tries to look laterally away from the side of the lesion. This is a case of congenital nystagmus. It can be horizontal, torsional. It can be initially pendular and they later become jerky. It increases with fixating attempt. This is seesaw nystagmus, wherein one eye raises up and intorts while the other eye shifts down and extorts. It is usually seen in upper brainstem lesions. This is a case of convergence nystagmus, retraction nystagmus, a type of jerky nystagmus with bilateral fast components towards the medial side. This is a case of Bruns nystagmus. The patient was diagnosed with right-sided cerebellopontine angle tumors. This is a low frequency and a large amplitude towards the side of the lesion and vice versa. Here we can see the cerebropontine angle tumor with the neuroimaging confirming acoustic schwannoma. According to some clinical pearls are, if nystagmus improves with fixation, it is likely congenital. Fixation versus central pathology, null point head posture, it is usually congenital. Red flags, when to vary, when it is asymmetric, when it has downbeat, when it is upbeat and seesaw. Alcohol can also be checked with nystagmus. The three key points to remember include pattern recognition is the key. Vertical torsional nystagmus is always pathological. Management is cause specific. Nystagmus is a sign, not a disease. Knowledge fact: 20th June is recognized as International Nystagmus Awareness Day. Thank you very much.
So thank you, Avengers, for completing your presentation right on time. So this time we'll take Dr. Kavita ma'am's comments first. So ma'am, please. Dr. Kavita ma'am, your comments, please. see, ma'am.
We can move on to the next judge.
Okay. Yeah. Dr. Sumita, ma'am.
Very good presentation. In the last slide, you said vertical nystagmus is always pathological.
Mostly, ma'am. Mostly always
Do you
pathological.
think it is always pathological, or have you ever seen any congenital nystagmus which is vertical?
I have never seen, ma'am. I don't know, ma'am.
Okay. What is your reference for that statement?
Ma'am, most books said you have to always probe into a vertical nystagmus because it would always be something deadly. So we should always check in for CNS also. That's what.
Oh, all
Yes.
right. And
Ma'am, is it like something congenital also? Do
yeah, it
we
can
have?
be. It can rarely be.
Okay,
Most
ma'am.
often, congenital is horizontal, but it can rarely be vertical as well. So that
Okay.
statement
Thank you, ma'am.
always is not
Yeah,
true.
I
Yes,
will
it's
make sure.
most
It's
often. Yeah, it's most often pathological,
Yes,
but
ma'am.
not always. Next question is: how would you classify nystagmus, and what is the basis of the recent classification system for nystagmus?
Ma'am, we can like classify it in various ways, which would like basically how
No,
we put
what is the what is the international classification system for nystagmus?
CMAS, ma'am.
Recent what?
Classification of
What
eye
is the full
movement
form?
abnormalities and strabismus. Yes, ma'am.
Okay, and what is it based on? The recent one is based on what?
Recent one.
The recent CMAS classification is based on?
Recently. Not sure, ma'am.
Okay, okay.
Yes.
Yeah, the earlier one was based on the etiology, and the recent one is based on the eye movement characteristics.
Okay,
So
ma'am.
I will pass the, I think the other judges can take the question. Those are my two questions for this team.
Thank you so much, ma'am. I think Dr. Kavita is back with us.
Yeah, I got disconnected. So one very simple question, like
ma'am.
how will she differentiate between whether it is vestibular or endpoint in case of endpoint jerk nystagmus, whether it is physiological or vestibular on ocular findings?
Ma'am, if it is vestibular, ma'am, am I audible?
Yeah, definitely you're audible.
Okay, ma'am. If it is end gaze point, it is accompanied with other. If it is end point nystagmus, it will either be accompanied with other ocular motor abnormalities. It can be that, ma'am. If it is just vestibular, even with the slight head turns and other things, there will be nystagmus even in the other cases.
Okay, and second question is, suppose you have a patient,
Yes,
right?
ma'am. Okay,
He
ma'am.
has a nystagmus with null zone. Practical question.
Yes, ma'am.
So 10 degree null zone coming in 10 degree, right?
Okay. Yes, ma'am.
So, and you consider right eye to be dominant. How you will proceed?
Right eye to be dominant.
He has strabismus with
Yes, ma'am.
nystagmus with null
Yes.
zone.
Yes,
and
ma'am.
right eye dominant.
Ma'am, is it
What,
we would
in which
first
eye you will do the strabismus surgery? Like how you will proceed?
we will operate. We will first check whether it is congenital or acquired, ma'am. Pick it up and then see. Ma'am, can my team member speak
Definitely.
for it? Yes.
Ma'am, am I audible?
Yeah, definitely.
Ma'am, first the null point has to be shifted to the primary position, ma'am.
Yes.
We should do the surgery for that. And if there is any
Hmm.
phase turn, we'll do the surgery on the fixating eye, ma'am.
Hmm.
So then, in the presence of strabismus and an abnormal head posture due to nystagmus, the head posture first will be corrected, ma'am, by operating the fixating eye only, ma'am. Then we will correct the strabismus, ma'am, by operating either the fixating eye or the non-fixating eye, ma'am.
So, but we can go simultaneously also, no? Both the eyes same time. What my point was to convey is,
Yes,
you
ma'am.
will do the nystagmus surgery in the dominant eye
Yes.
and the strabismus surgery in the non-dominant eye. This was
Yes,
the
ma'am.
basic thing I wanted to convey.
Okay, ma'am. Yes, ma'am.
Okay.
Yes, ma'am.
Thank you, ma'am. So those were very valid points which ma'am gave. So do we have Sovita ma'am with us, or ma'am couldn't join back? Ma'am, are you there?
Yeah, I'm there.
Ma'am, your comments, please.
Yeah, well presented. And I think most of the points have been asked and covered now for basic at a resident level. I'm okay to move in for the third.
Yeah, thank you, ma'am. Prachi ma'am, would you like to add something? Ma'am, you're on mute. Ma'am, you're on mute.
Yeah, so good presentation on a complex topic. So congratulations for the topic itself, I would say first. So a couple of questions. Any idea what is fusion maldevelopment nystagmus?
Yes, ma'am. Nowadays, the latent and the latent manifest nystagmus has been grouped under fusion maldevelopment syndromes, ma'am, in the recent classification, ma'am, according to CEMAS, ma'am.
Any characteristic you can tell me about it?
In that, usually there is monocular nystagmus, ma'am, in the latent nystagmus, ma'am.
And any
None,
eye
ma'am.
drop can work for reducing nystagmus?
Ma'am, brinzolamide eye drops can be given, ma'am. They improve the foveation, ma'am. So we give that nowadays, ma'am. Yes, ma'am. Thank you, ma'am.
Thank you, judges,
I
for your.
think it was a very nice presentation. She has covered almost all types of nystagmus in a very short period of time. Like she had all the cases.
Thank you, ma'am. Thank you, ma'am.
Yeah.
So congratulations, Avengers. So we'll be going to the next team, Team 3, Optic Avengers. Please share your video. Sorry, your presentation.
Hello. Ma'am, am I audible?
Yes,
Yes, you are.
Ma'am, shall I start?
Dr. Harshal, will you start?
1 minute.
Okay.
You can start now.
Good morning, everybody. Good afternoon, everybody. I'm presenting the seminar on the topic non-arteritic anterior ischemic optic neuropathy. Just a minute.
Harshal, you can restart the timer. Just stop it and restart.
Just a minute. The slides are not moving.
Yeah. Yeah, now
Okay.
it's yeah. Harshal, can you restart the timer for them, please? Yeah.
Yes, ma'am.
Yeah.
You can start.
Thank you. Good afternoon, everybody. I am presenting the seminar on the topic non-arteritic anterior ischemic optic neuropathy. Let's start with the ischemic optic neuropathy. What is ischemic optic neuropathy? It is an acute painless optic neuropathy due to circulatory insufficiency. Occurs mostly in more than 50 years of age people and more frequently occurs at the anterior optic nerve head, which is called as anterior ischemic optic neuropathy. It can less frequently occur behind the optic nerve head, called as posterior ischemic optic neuropathy. In this diagram, we can very clearly see the anterior occurring at the optic nerve head is AION, while occurring behind the optic nerve head posteriorly is PION. Coming to AION, it's the most common cause of acute optic neuropathy in older age groups. It leads to a segmental or a generalized ischemia of the anterior part of the optic nerve. This term ischemic optic neuropathy was given by Miller and Smith in 1966, while anterior word was added by Hare. Why this anterior word was added by Hare? Because he studied the anatomy of the blood supply, and that's why he concluded the anterior involvement in the ischemic optic neuropathy in AION. It leads to a rapid onset of painless unilateral vision loss. It could be classified into AION, PION, and AION can be further classified into two groups, an arteritic variety and a non-arteritic variety. Coming specifically to NA-AION, that is non-arteritic variety. It covers 90 to 95% of the total AION. The mean age of presentation we generally consider as 60 years. The visual acuity of these patients could either go from 6/6 to even hand movement to even no light perception. It is having a rapid onset and a stable course. It is less severe visual loss compared to the arteritic variety. Coming to first the blood supply, we can see the blood supply of the optic nerve can be divided into these regions as a superficial nerve fiber layer, prelaminar region, lamina cribrosa region, and a retrolaminar region. The ONH, that is the optic nerve head, is almost entirely supplied by the posterior ciliary artery. Very important, the distribution of this PCA is different in various individual. That's why this PCA branches creates a watershed zones on the optic nerve head. Coming to the blood flow in the ONH is calculated by using this Hare formula, that is mean BP minus the intraocular pressure. That's why we can see that there is a role of BP as well as IOP on AION. Blood flow depends on both these factors. This is important aspect for ocular risk factors. Disc at risk. Disc at risk refers to a crowded disc, or disc at risk is the strongest risk factor here. It refers to a small cup to disc ratio which is less than 0.3. We can see in the diagram the cup to disc ratio is very small. This leads to a crowded disc exacerbating the chronic obstruction to the exoplasmic flow. These are the risk factors as we discussed. Systemic could also be sleep apnea, arterial hypotension, hypertension, and diabetes. What is the pathophysiology? All these factors leads to insufficient optic nerve circulation, causing ischemia and compression of the nerve fibers. This leads to progressive nerve damage. Clinical features, as we discussed, acute painless loss of vision with a RAPD and a normal anterior segment. Fundus shows optic disc edema, as we can see in the image, with sectoral pallor important and retinal nerve fiber hemorrhages. Visual field defects characteristically show altitudinal visual field defects. These defects can also be seen in hemiretinal vein occlusions or artery occlusions and optic neuritis. This is important. The differential diagnosis includes arteritic AION, compressive optic neuropathy, amiodarone optic neuropathies, and optic neuritis. We have not that time to differentiate all these in current scenario, but this slide is very important. Investigations, routine ophthalmic investigations like a fundus photo, perimetry, and FFA are mandatory to look for the filling defects, perimetry to look for the visual field defects. We have to go for the routine blood investigations. Lipid profile is important. Cardiac evaluation is important. ESR, CRP to look for the markers of inflammation. Temporal artery biopsy in cases of arteritic or giant cell arteritis if we suspect. MRI for optic neuritis if we suspect those conditions. Treatment, generally there is not much treatment options for AION. Medical treatments are not much proven on trials. We could opt for aspirin, levodopa, hyperbaric oxygen, or bimonidines, but these are not much into practice. One recent advancement has been a QRK207, a caspase-2 inhibitor, which inhibits apoptosis, has been tried. Surgical options, a decompression trial was done by vitrectomy, but not proven good. Prognosis, important to know, 40% patients go into spontaneous resolutions. 30% gains 3 or more lines, while 20% loses 3 or more lines. Thank you.
So congratulations, Optic Avengers. It was a very comprehensive presentation. So now we'll start with Dr. Prachi ma'am's comments, please.
Okay, a very good presentation. I would say very well covered. First question is, you mentioned about the field effect, right? What kind of altitudinal field effect do you get commonly in ischemic optic neuropathies?
Mainly we say that we get a superior altitudinal defects, as mainly we in the fundus photos we can, as we could appreciate that the patients generally have an inferior sectoral pallors, more commonly involving the inferior aspects.
How will you differentiate it from optic neuritis?
Optic neuritis generally does not, like if we come on to first on the basics of optic neuritis generally has patients in pain on eye movements, while non-arteritic AION does not show pain on eye movements. Second feature, we can also comment on the color vision of these patients. Non-arteritic AION patients generally have a color vision in correspondence to their visual acuities. If the visual acuity is decreasing, correspondingly the color vision decreases. While in optic neuritis, patients can have an in-proportionate decrease in color vision. A patient of optic neuritis can have a distant vision of 6/6, presenting with a profound loss in his color visions. If we see fundus findings, the patient can have comparatively decrease or mild edema in optic neuritis, and hemorrhages on optic neuritis patients are rare to occur.
Thank you.
Okay, thank you, ma'am. Dr. Sovita ma'am, your comments, please.
Very well presented, and most of the points have been covered. How will you distinguish it from PION? Do you know what is PION?
Yes, ma'am. It's a PION is mainly a posterior ischemic optic neuropathy, which is involving the posterior segments. To differentiate from PION, as the patient is not much having any symptomatics and the optic nerve head on fundus examination mostly is normal in PION, we have to go for investigations of MRI for PION diagnosis. If patients present with same symptoms of AION but does not involve optic nerve head much, having a normal optic disc initially, then we suspect a PION, which is a very rare entity to occur.
Is there any other optic nerve head anomaly or optic nerve head finding which could be a risk factor for NAION?
Ma'am, the disc at risk that we talked about could be a risk factor for
That's
it.
the most common risk factor, but anything else, maybe in the same disc? This eye has a disc edema. You are not appreciating disc at risk in the same eye. In the contralateral eye, you are trying to see whether there is a disc at risk or not. So given disc at risk, we are sure that this is NAIN based on age profile and the morphology of the disc edema. Now, if the other eye is still not disc at risk, or it's a disc of some pathology, which will give you a hint that this could be, it's a rare thing, but it still can give you. Maybe I would give you a clue if it's a
could be presence of drusen.
finding for a pseudodisc. Yes, very good. Pseudodisc edema finding. So drusen is another etiology for NAIN.
Yes, ma'am.
And in the latest thing, what is the other antibody association which has come out with NAION? Most of the NAION patients are now being positive for one entity which is associated with optic neuritis.
Sorry, ma'am, I don't have idea
All the
about that.
participants to switch on their camera when they're answering the judges' questions. Yeah.
Yes, ma'am. Sorry, ma'am, I don't have idea about the antibody.
So we do find most of the NAIN patients have MOG antibody positive nowadays.
Okay, ma'am. Okay.
So thank you, ma'am, for such
Well
valuable.
presented, but.
Thank you,
ma'am. Dr. Sumita, ma'am, kindly give your inputs.
Yeah, excellent presentation.
Thank you, ma'am.
I have two questions for you. One is treatment of AION is aimed at resolution of the loss of visual acuity or visual field defect. Answer yes or no and justify.
The treatment of ma'am, sorry, I cannot hear the full question. Can you repeat, please?
Can you hear me now?
Yes, ma'am. Yes.
Treatment of NAION is aimed at resolution of the visual acuity loss or the visual field defect. Yes or no, and please justify your answer.
The treatment of NAION, I don't know the major details of it, but it is not specifically aimed at restoring the visual acuity of the patients.
Okay, so your answer is no, then justify your answer. What is it aimed at then?
That I don't have much idea about it, what it is specifically aimed at. But it is that I know that surely that is not specifically aimed at restoring the visual acuity of the patients, because it is an ischemic. So we are more aiming to protect the nerve and to protect the blood supply of the nerve. We are not specifically aiming to preserve the visual acuity of the patients.
Yeah, correct. So yeah, I think you indirectly answered the question. So the aim is to prevent any recurrence or similar occurrences in the other eye. Okay, so the next question is, I think one of the judges also asked about posterior ischemic optic neuropathy.
Yes.
Can you name a couple of scenarios where you see posterior ischemic optic neuropathy? Causes, basically, I'm asking for the causes.
Causes. Posterior. It could be a part of arthritic ischemic optic neuropathy.
It has a different systemic etiology. You can
the
look
classification
that
classification that I studied for PION, basically it could be also arthritic, non-arthritic, or post-operative. They gave it could also be a post-operative, like some cardiac surgeries they mentioned, some spinal surgeries could also lead to a PION.
Good. Yeah, thank you. Excellent.
So great going, Team Optic Avengers. Dr. Kavita, ma'am, would like to thank you for your question.
Yeah, it's a very common thing. how do you distinguish between a very mild diabetic papilledema and maybe how will you distinguish whether it is a diabetic one, because most of the patients are diabetic nowadays?
Yes, ma'am. Ma'am, for like a basic thing that we can comment on for a diabetic disc edema or diabetic papillopathies could be that the patient specifically will have a history of diabetes per se specifically, and the fundus of the patients could show the signs of diabetic retinopathy, that the patient has a mild or a moderate exudation or some vascular changes with respect to diabetic retinopathy changes on the fundus photo of the patient. The papillopathies in diabetics is mostly concerned with more of a pallor than edema, while in AI1 we say it is more of a hyperemic disc initially than pallor.
Yes.
Ma'am, any further comments?
No, that's okay.
Okay. So thank you, Team Optic Avengers. It was a nice presentation.
Thank
So I
you,
think
ma'am.
all the teams are very well prepared today. So we'll invite our next team, Team RRR. Please share your presentation.
Good afternoon, ma'am.
Good afternoon. Can you please share? Yeah.
Yes. Good afternoon, everyone. Today I'm presenting on the topic traumatic
Let me
optic
start the
neuropathy.
time.
Just
Hello?
wait.
That one. You can start now.
Yes, ma'am. I'm presenting on the topic traumatic optic neuropathy. It is an uncommon cause of visual loss following penetrating or blunt trauma, but the consequences can be devastating if it's bilateral. This condition is a prime example of men being men, as the most majority of the patients affected are young adult males, with 20% of the cases occurring in pediatric age group. It is classified according to the on two bases. First, on the basis of site of injury of the optic nerve. One is the optic nerve head, then the intraorbital segment, then intracanapular segment, and then the intracranial segment. On the basis of injury, there are two types of traumatic optic neuropathy. First is the direct, in which there is anatomical destruction of the optic nerve occurring from projectile injuries, high velocity injuries, or fracture of the bone surrounding the optic nerve. In indirect traumatic optic neuropathy, it is caused by the transmission of forces to the optic nerve from a distant site without damaging the eye structure surrounding, without damaging the surrounding structure. The deformative stress transmitted from the skull following the blunt trauma is concentrated in the region of the optic canal, mainly the intracanapular segment of the optic nerve. The pathophysiology behind the indirect optic nerve injury is multifactorial, and the two primary and secondary injury mechanism has been proposed, in which following the trauma, external shearing occurs due to direct mechanical trauma, and there is immediate loss of retinal ganglion cells. In secondary injury, there is swelling of the optic nerve inside the optic canal. This results in compartment syndrome. This further results in vascular ischemia, which results in reduced blood flow to the retinal ganglion cells, and then it results in apoptotic cell death. This primary and secondary injury has been the basis for medical and surgical treatment. It occurs mostly in young adults, the most common cause being road traffic accident, falls. In pediatric cases, most cases are because of the falls. The clinical, since it is a trauma case, our first primary aim should be management of ABC, then the documentation of history and the clinical examination with visual acuity should be mentioned at the first visit. There can be sudden visual loss from little vision loss to PL negative. Then there can be color vision impairment. There can be visual field defect. It can present with relative afferent pupillary defect. On optic disc changes, initially there can be normal fundus. In late stages, optic atrophy after 6 weeks can be seen. In neuroimaging, many clinicians differ whether CT should be done or MRI should be done, or they can do both also. The MRI should be done after ruling out intraocular foreign body. The management option has also been it has been deferred from clinician to clinician. Observation to the high corticosteroid treatment to surgical decompression has been done, but all in studies it has been shown that all three, after a long treatment protocol, all three have given same visual acuity result. The prognostic factor had been poor prognosis factor had been with no light perception at presentation, with severe optic avulsion on imaging, and delayed treatment post injury. Prevention of this disease can be done by preventing the trauma by using helmet in high risk activities and protective IVR in sports and hazardous work environment. Future research has been done into for using erythropoietin for treating the patient, and a need for large-scale randomized control trials should be done, because there has been less studies done about traumatic optic neuropathy. In conclusion, it is a vision-threatening condition requiring early diagnosis and treatment. Imaging studies are crucial for evaluation. There has been no accepted universal accepted treatment. It depends on clinical discretion, and prevention should be done through protective measures. Thank you.
So thank you, Team RRR, for finishing right on time. So this time, we'll start with Dr. Sovita ma'am for your comments. Please stop sharing your screen. Yeah.
Dr. Anuvati, please also switch on your video.
Yes, ma'am.
Yeah, congratulations. Very well presented and covered most of the parts. But since we are dealing with neuro-ophthalmology also back-to-back 2 topics, I would like to ask you, can you grade RAPD?
Yes, ma'am.
Discuss the
RAPD can
grades
be
of
divided
RAPD.
into 5 stages. First grade is initial constriction followed by dilation. Then second is pupillary stall followed by dilation. Then third is sudden constriction, sudden dilation. Then there is dilation following 6-second illumination by the torchlight. Then constant dilation. It's grade 5 is constant dilation.
So second one is pupillary stall and third one
Yes,
is
ma'am.
pupillary escape.
Stall then dilation.
And what do you want to advise in a CT or MRI? What are there some certain specific things which you want to look for?
Ma'am, for CT scan, we should go for the brain and orbit complete CT scan with 1 millimeter cut section of the orbit nerve.
What else do you look for? So when you ask, only when you get the CT films, if you have some 3-4 things or 2-3 things in your mind, you will look at them to rule out whether it's a traumatic optic neuropathy or things associated with it.
Ma'am, we will see for fracture points. First, we'll see for bony fracture points. And then, ma'am, we'll see for orbital, any hematoma.
Okay. So you look for any intracranial bleed, you look for any orbital wall fractures, you look for any muscle entrapment, you look for any optic nerve avulsion.
Yes, ma'am. Optic nerve avulsion, yes, ma'am.
Okay.
Ma'am, any foreign body.
Any foreign body. Good.
And also, ma'am, I'm Dr. Ravi's team RRR. Also, we look for any fragments, whether there is any impingement of any.
Impingement on the optic nerve.
Yes, ma'am.
What is the ideal treatment duration to start IVMP?
Ma'am, we should start with high dose intravenous steroid. Ma'am, 1 milligram per kg for 3 days.
Okay. Within what hours does the patient present and then we start?
Ma'am, after 6 hours, after 6 hours, 6 to 8 hours.
Ma'am,
Literature says within 8 hours.
Within 6 to 8 hours, it is the golden period, and as soon the earlier we start, the more we are able to restore the cells, prevent
Restore
any
the
loss
vision.
of function. But some papers also acknowledge that if we started within the first 48 hours also, they have also shown significant results. provided we have ruled out any intracranial bleed or lesions, ma'am.
Very good.
As according
Yes,
to the
So the
crash.
next question was,
injury,
what
yes,
was
ma'am.
the contraindication for IVMP?
Yes, ma'am.
So in presence of
Yes, ma'am. According to the crash trial, ma'am.
Crash trial, yes, ma'am.
yeah,
Thank you.
I think other judges can take on.
Yes, thank you, ma'am. Thank you so much. Dr. Sumita, ma'am, kindly give your comments.
Yeah, sorry. Very good presentation. And yeah, can you name some differentiating signs between, say, a patient presents to you with disc edema? What are your differential diagnosis for any patient presenting with disc edema? This is not particularly related to Tron, since we are dealing with neuro-ophthalmology. It's just a general question.
Ma'am, disc edema. Differences of disc. Ma'am,
Unilateral disc edema, your differential diagnosis.
Ma'am, differentials for disc edema can be, ma'am, can be papilledema due to, or ma'am, due to ma'am, idiopathic intracranial tension, and ma'am, optic neuritis.
Ma'am, so
Ma'am,
for
various causes
unilateral
of
disc
optic
edema,
neuritis.
ma'am, good afternoon, ma'am. I'm Dr. Ravish. Can I help my teammate?
Yes.
Ma'am, so for unilateral disc edema, we would want to rule out papillitis. We would want to rule out AION. We would also want to rule out neuroretinitis. Even though hypertensive retinopathy, it is mostly bilateral, but it can also be rarely present in unilateral cases. We would want to rule out ischemic CRVOs, any infiltrative optic neuropathies, and in Foster Kennedy syndromes. In Foster Kennedy syndrome.
Yeah, good answer. And yeah, I think that's it. No questions, no other questions from me.
Thank you, ma'am. Dr. Kavita, ma'am, your questions, please. Dr. Kavita, ma'am, are you there? Yeah, she's there.
So, apart from that, it's a neuro-ophthalmology case. What you will see in a traumatic optic neuropathy patient in anterior segment, which should never be missed.
Sorry, ma'am, could not catch the last part.
Anterior segment finding, which should never be missed in
Ma'am, relative afferent pupillary defect.
that though we have already discussed the grading and
Yes, ma'am.
everything. One more important thing which you should always examine in cases with traumatic optic neuropathy, if it's a blunt injury. I've given you the hint.
Ma'am, hythema or eye movement.
Yeah, anything else? Maybe your colleague can answer.
Good afternoon, ma'am.
Yes.
Ma'am, so based on the anterior segment findings, we would also want to schedule our treatment if there is a raised intraocular pressure. So it is one of the indications for an urgent surgical intervention in case of traumatic optic neuropathy, because it might really the patient's eye might be progressing into a compartment syndrome.
No, anything else?
Ma'am, any case of penetration, perforation?
No, it's a blunt injury.
Blunt trauma.
What I wanted to convey is the angles are to be examined very carefully for the recession part. You are not just treating a traumatic optic neuropathy, but along with it, you are seeing certain things in the angle also. And second thing, you as previous doctor was discussing about the treatment part. So practically, when we give IVMP to the patient, you should ask the drop rate to the sister, what drop rate she is giving, because that is very, very important in this, because you are continuously monitoring everything, all the parameters. So that is also very important. That is a technically when you come into practice, then okay.
Yes, ma'am.
Yeah, that is also very important part.
Yes, ma'am. Yes, ma'am.
Just you write the prescription and send the patient to the ward, and you don't know if a junior sister is there, junior staff is there, she will not know how long you are supposed to give IVMP.
Over 3 to 4 hours, slow infusion, slow IV.
Okay, thank you.
Thank you.
Ma'am, for so many valid points being discussed. Dr. Prachi, ma'am.
So yeah, a very good comprehensive presentation. So congratulations for that. Only one question. What investigations can you make use of for documenting disc edema and optic nerve function?
Ma'am, we can do the fundus photo. Fundus photo, or ma'am, also on MRI, we can see the inflammation. And ma'am, on
anything objective?
Objective.
Good afternoon, ma'am. So, ma'am, we would want to assess the visual acuity, the visual fields. Also, we would want to assess the color vision contrast sensitivity of the patient.
Ma'am, OCT.
We can make use of OCT, optic nerve head, as well as VEP. Okay, so VEP is another thing that you can really make use of to monitor the optic nerve function. Okay. And B-scan ultrasound. Okay, sometimes, especially in kids, sometimes it can be very useful to measure the disc edema and see how things are.
Thank you.
Thank you.
Thank you, team.
Even an OCT will be a good guidance for that. OCT with RNFL and optic disc area. It will give a good guide.
Thank you.
I just wanted to add one point for residents that they should know the 7 rings of trauma. So whenever it's a case of Tron, that's a very common question which will be asked, just like ma'am asked now ago about the angle. So the 7 rings of trauma, all of you should know.
Yes, ma'am.
Thank you, ma'am.
Thank you.
Thank you, judges. You guys are preparing them for their final vivas. So we'll come to the next and the last presentation of today's. Team 5, Annulus of Vein, please share your presentation.
So good afternoon. I'm Dr. Shruti from the team Annulus of
1 minute, 1 minute. Let me start the timer.
Okay, sir. Okay, sir.
You can start.
So good afternoon. I'm Dr. Shruti from the team Annulus of Will. So what do you find common in these pictures? Is all of these kids have spectacles. So today we'll be discussing on approach to pediatric myopia. So to begin, let's see a little story. We have 8-year-old Master Rohan. So like every other kid, he is also addicted to his video games and he loves his iPad. So eventually, he starts developing trouble seeing the blackboard. So his parents take him to the doctor and now he is diagnosed with myopia. So let us see various options to treat myopia. We can use spectacles, contact lenses, increasing the outdoor activities, usage of DIMS lenses, and low-dose atropine. So now let us see each in detail. So for myopia, we can use concave lenses in the form of either spectacles or contact lenses. And then next we have increasing the outdoor activities. So there are various theories and mechanisms on how this help in preventing myopia. So first, there is augmented exposure to bright light. There is increased vitamin D levels. Then there is reduction in accommodative demand and accommodative lag. And then there is reduced near work. So outdoor activities helps in preventing myopia in school-going children. But our Rohan is not interested in playing outside and he goes back to his older ways. And now his myopia worsens and his parents are worried. So they ask for another treatment option. So next, we have defocus incorporated multiple segment lenses. And this works on the principle of myopic defocus. So in myopia, we know the rays, they fall in front of the retina. And with the regular single vision correction, these rays are focused on the retina and the peripheral rays, they fall behind the retina, causing a hyperopic defocus. So our eye reacts to this by increasing the axial length. But with our DIMS lenses, they create a myopic defocus. That is, these rays, they fall in front of the retina and thereby there is reduction in the progression of myopia. So there is a central 9 mm zone for myopia correction and then there is peripheral plus 3.5 diopters to induce this myopic defocus. But with these various types of glasses, our Rohan is not interested in wearing glasses. So the parents ask for another treatment option. So we come to ortho-K lenses, which are worn at night. So here there is a central curve with two steep curves, and then this creates a positive and negative pressure impacts. Thereby, it alters and flattens the surface of cornea. So this is worn at night for about 8 hours, and it could be quite cumbersome to the child. So the parents ask for another treatment option. And next, we have dual multifocus soft contact lenses. So here, it also works on the principle as that of DIMS lenses, that is myopic defocus. So here, there is a central area for myopia correction, and there are alternating zones of plus power to induce myopic defocus in the eye. So the parents ask for any other topical preparations. Yes, we have low dose atropine, mostly 0.05% atropine, which is used at night. Here, it has both muscarinic and non-muscarinic effects. So here, by muscarinic effect, they induce increase in choroidal thickness through modulation of dopamine release. And so there is reduction in axial length elongation. And by non-muscarinic effect, there is direct influence on scleral fibroblasts, and it interferes with scleral remodeling. So here there is inhibition of glycosaminoglycan production, and thereby it inhibits the growth of eyeball. So to summarize, we have the newer advancements in the treatment of myopia, like increasing the sunlight exposure, usage of DIMS lenses. Then we can use ortho-K lenses at night, usage of dual multifocus soft contact lenses, and then low dose atropine. So that's all. Thank you all. Thank you for your patient listening.
Thank you, Anula. It was a very interesting video, I might say, presentation, I must say.
Right.
So let's start with Dr. Sumita, ma'am.
Hi, very nice presentation. You carried it in the form of a story, which is interesting. Yeah, so I'll just ask you a simple question. What does ATOM-1 trial, what did it evaluate?
So it is the study for the usage of atropine in myopia, one study. It was conducted for 2 years, where they studied about usage of atropine 1% drops to study the efficacy of atropine 1%. It was conducted for 2 years, and it was used in unilaterally, like one eye. It was
Atropine 1% versus?
It was to study the efficacy of
No. What is the other arm? One arm is atropine 1% and the other arm is?
No drops were used.
No drops? In medical, in medical field, do you ever not give medication to one arm and give medication to one arm? What would you give to the other arm?
Placebo drops were used.
Yes. Okay. So, and what did ATOM-2 trial?
ATOM-2 study, it was comparison of atropine 1%, 0.05%, and 0.01%. So it was so at the end of the study, it was a five-year trial, and at the end of the study, 0.01% was considered to be best with minimal side effects and minimal rebound phenomenon.
Okay, excellent. And one last question from a practical point of view. In a patient with myopia, along with monitoring of refractive error, is there anything else that you would like to closely monitor for progression?
Axial length elongation.
Excellent. Yeah, so biometrics, basically keratometry and axial length. Excellent. Good.
So we'll go to Dr. Kavita ma'am's comments, please.
Yeah, so you can divide this lecture into 5 points actually. So first, coming to the atropine, as she has already told, she has asked about the studies. So there are various school of thoughts in this. Like now they are coming with higher concentration also. At times 0.01% is not effective in OD dosage. Some people give it BD. Then some people switch it over to 0.05%. Initially when atropine was not coming in the market, not available, I was personally making atropine for my patients. And so that is to be decided according to the patient. First point. Second point, coming to the spectacle correction and the outdoor activity. Outdoor activity is effective in the pre-myopic age. Can you get it? Like when the child is not myopic, but parents are myopic. That time, if you increase the outdoor activity, he is not going to get myopia. Post myopia, also people are advising, but actually, then it is not going to affect much of your axial length. Third point, in a patient, if a person, say 5-year-old kid comes to you and he has myopia, the most important thing is you do all your investigation, you do cyclo, everything, whatever, homemade, whatever you are doing. But for every patient, make sure that you document their complete biometry as the colleague doctor has told. The biometry is very important and it has to be done on the same machine every time. And it's better to go for IL Master 700 or 900, this one. So this, you will have all the parameters. Every time you check, you will know very minimal change also in that. Now coming to spectacles, she spoke about DIMS. So there are various technologies available. HALT is there. You have this DIMS is MyoSmart. Then Zeiss is there. So everything is there. So the basic difference is this in Hoya lenses, you get the circular, which she has already demonstrated. Other lenses, you have annular segments. Concentric cylinders are there with the same effect. The basic thing is you are converting the peripheral hyperopic focus into a peripheral myopic, changing the shift. Now I think what they can be asked is various type of lenses, spectacle lenses available for controlling myopia. Now they can tell about all the lenses, I think. Then anything else? I think done.
Concave. High index lenses. High index lenses to correct for the myopia correction. High index lenses for high power children, so that
No,
the thickness.
you talked only about DIMS technology, no? So there are 5 technologies, beta. Go and read those technologies. 5 technologies coming in the market for correcting myopia. Okay. So every people, some are using SLR lenses, some are using Zeiss lenses, some are using Hoya lenses. So various lenses are available, and still certain lenses are under evaluation. They're going to come in future. So that is important. So when you read, if I tell you, you won't remember. I'll just put a question in your mind so that part will you make you read, and then you'll remember it for long. Okay.
Thank you.
Okay.
Thank you, ma'am, for highlighting the important points. Dr. Prachi, ma'am.
So good presentation. Okay. 2 questions again, maybe. What is myopia of prematurity? And do you use these treatment modalities for treating them?
Myopia of prematurity mostly seen in children who premature babies. It may be associated with retinopathy of prematurity or without post-treatment of retinopathy of prematurity. Spectacle correction may be given. Spectacle correction can be given to these children, then or in the form of contact lenses as well.
This is something that probably you should remember. So this myopia is mainly because of the anterior segment being different. Okay? It's not because of an axial elongation. So the other myopia treatment measures are actually not required for these babies, or probably it's one of the contraindications where you don't have to give these myopia control measures. Yeah. And how would you differentiate that from pseudomyopia? What is pseudomyopia?
Pseudomyopia is due to accommodative spasm or because of excess accumulation. It's not actually myopia.
So how would you diagnose that?
It can be corrected by giving after doing refraction, we'll identify that by giving plus lenses, it can be corrected.
Refraction using what?
Cycloplegic refraction.
That's important, right? So cycloplegic refraction usually means that there is no myopia. That's good.
Thank you. Dr. Sovita, ma'am, any comments from your side?
So I wanted to highlight that apart from axial length and refractive error, we need to document accommodation every time. So a dynamic retinoscopy can be done because we have to rule out accommodation spasm. So if a child with changing myopia, variable myopia presents to us, and in a very shorter duration, with the onset of esotropia, then we should go back and do an accommodation to find out whether there is a lead of accommodation or a lag of accommodation. So variable myopia with esotropia would give us a lead of accommodation if there is accommodation spasm. Versus in most of our myopes, there would be a lag of accommodation. So a cover test, accommodation and its amplitudes, axial length, and refraction has to be done. But also they do nowadays peripheral refraction wherever possible. This completes our myopia workup.
Yeah, I would like to comment one thing. Dr. Jiten Jethani has come up with a peripheral myopia device to measure the peripheral myopia.
And there are a couple of them actually. One is from LV Prasad. So I think
Yeah.
this is
Yeah,
a
one
bit
is
too
from LVP
probably
also,
a
He
bit
has done at his
too
own
much for
level.
their level to discuss maybe. I think.
Yeah.
Mhm.
That's all. I think we can finish the first round maybe.
After such an
Very creative presentation. Very creative.
Thank you, ma'am.
Well done.
So I think all the participants have actually excelled today. So we'll go to the next round, the creative round. Dr. Harshal will take over. I'll be sharing my screen. Dr. Harshal, please.
Hello everyone. We'll start with round 2. The basic rules are like team members will collaborate to give a creative presentation in the form of reel, music, dance, etc. and the topic of interest. The maximum mark will be per presentation will be 20 marks. And the obvious theme is like pediatric ophthalm, squint and neuro ophthalm. Can we start with team 1, macular goals?
Yeah.
Guys, are you ready?
All my life, I wanted to be a football player. I have some problem with my vision. I'm not able to see one side and something is off. Actually, a few days back, I fell down from a bike and I just hit my head. That's it.
In the examination room, the doctor carefully explains the situation. The trauma to the lateral part of his eyebrows, although a minor injury, has transmitted all the way to the optic canal. This is where the optic nerve sheath is adherent to the periosteum of the canal. This resulted in a shearing force secondary to the trauma, causing damage to the optic nerve.
Now, unfortunately, due to my carelessness, all my dreams have been shattered.
This could be prevented by following the appropriate safety measures and avoiding distractions while driving.
Thank you, team A. Excellent presentation. Ma'am, for the time limit, we are just reducing judges comment to 2. So, like, Dr. Prachi, ma'am, can you just give some input about the video?
It was very nice. I like that. No other
Would you like
questions.
Dr. Kavita, ma'am?
Yeah. The video is nice and the take-home message is very nice because most of the youngsters we see with a lot of road traffic accidents and they suffer for whole life. It's just they are just 20, 23, 24. That's it. and they suffer for their whole life, and we, being doctors, doing our best, cannot provide what they were having. So it's really very important to take the preventive measures whenever the person is driving. That was the, I think, the take home message of the video in the end, when she showed the person wearing the helmet. So that is the most important thing, especially for the head injury. That is the worst thing that can happen.
Thank you, ma'am. Can we have next team?
Yeah, just one second.
Team Avengers.
The unseen struggle. Every child deserves clear vision. You're sitting in class, staring at the board. The letters look blurry. You blink, squint, rub your eyes. Still nothing. This is not laziness. This is undiagnosed vision loss. The child is playing cricket. The bowler throws the ball, but the child sees two balls. He swings at the wrong one and misses badly. Poor coordination? Maybe it's an eye problem.
Why do my eyes look different? Amma, my eyes moves differently.
It's fine, it'll go away on its own.
Naughty eye, it looks cute.
It'll grow out of it. No need for glasses now.
Squint is not just cosmetic, it affects vision for life. A simple eye test before age 5 can change a child's future. Don't wait. Act now. Check their eyes today. Your child has amblyopia, but if we treat it now, we can save their vision. Your child's vision today shapes their future tomorrow. In India, millions of children suffer from untreated vision problems. Squint, lazy eye, and blurred vision are not just small issues. They affect learning, confidence, and life forever. Save their sight. Squint, awareness, pediatric eye health.
Very good presentation, Team Avengers. Ma'am, Dr. Sumita, ma'am, would you like to take this, ask any questions?
Yeah, no questions as such. So this is meant, all the videos are meant for public awareness, is that right?
Yes, yes, ma'am.
Sure, I think they have covered most of the points. Very nice video. But yeah, I just want to know, did you get help for the animations?
Ma'am, I'm Charishma, ma'am, from Team Avengers, ma'am. Ma'am, I'm actually little interested in animations, and I did it by myself. For voiceover, we took the help of an art video coverage person here at our institute. He just combined the voiceover and this for us, ma'am.
May I know what app you used for the animations?
We app, ma'am.
We app.
Yes.
Oh, very good.
Thank you, ma'am.
Dr. Sovita, ma'am, would you like to ask some question?
No. I don't want to ask. I want to congratulate them. It's well covered. The sentence where the mother says that it will just go away of its own is a necessary statement as an eye-opener, which brought back at the end.
Thank you.
Thought-provoking concept.
Thank you very much.
Thank you so much. We'll heading to next team, Optic Avenger.
The eyes don't see what the mind doesn't know. Every day in our eye OPD, we see children losing vision due to cortical causes like hypoxic brain injury, cerebral palsy, and drug-induced neuropathy. Yet, do we truly prioritize them? Telling parents nothing can be done is heartbreaking. But is it really true?
हमारे बच्चे के सर में इन्फेक्शन हो गया था, उसकी चक्कर से उसकी आँख में दिक्कत पड़ी। आँख जब दिखाए हम आकर के तो सब लोगों ने देखा तो बोलने लगे कि इसकी आँख की नस सूख गई है। उसके बाद में जो बच्चे को दिखता था उससे और भी कम दिखने लगा है। जब करीब सामान लेकर के आते हैं तब वो देख पाता है।
But you know, happiness can be found
even in the darkest of times, if one only remembers to turn on the light.
There is still hope. We just need to see it and act, rather than ignore it. With low vision aids, magnifiers, special lenses, and assistive devices, these children are reading, recognizing faces, and regaining confidence. Once dependent, they're now independent, learning, and thriving. Even without sight, their eye is still vision.
लो विजन एड के बारे में पता चला हमें, तो उसकी वजह से अच्छे से ग्लासेस हैं, अच्छे से चश्मा है। उसकी वजह से जो पहले संभावना नहीं थी अच्छी जो देखभाल की, कि नहीं देख पा रहा था, अब काम कर रहा, पढ़ाई लिखाई सब बढ़िया से अच्छे से करने लगा है।
Very good, Optic Avengers team. Dr. Prachi ma'am, would you like to comment anything?
It was a good video. I couldn't actually hear in between. I don't know if it was just me or yeah, but the message that was trying to get across was quite clear. So yes, congratulations.
Thank you, ma'am. Dr. Kavita ma'am.
Yeah, it was a nice video. Nice video.
Thank you, ma'am.
In fact, the previous video was also very nice. Excellent. For public awareness, you should put that in your site. So all the things are covered, like most of the common things. This one was a rare thing. Not where we get few patients, and other patients are more. See where patients are less.
Thank you so much, ma'am. Coming to team 4, RRR.
ये सूचना जनहित में जारी।
हेलो, गुड मॉर्निंग डॉक्टर साहब।
गुड मॉर्निंग, बैठिए।
ये मेरी बच्ची है जो कि बहुत ही नालायक है, पूरे टाइम फोन चलाती रहती, मेरी तो एक भी नहीं सुनती। आप देखिए क्या है इसका।
क्या दिक्कत है बेटा आपको?
दिखता नहीं है सर।
कब से नहीं दिखता बच्चे?
बहुत टाइम हो गया सर, कुछ नहीं पढ़ पाते हैं बोर्ड का।
अच्छा, इनकी एक नजर की जांच करानी पड़ेगी पहले।
अब ये फाइनल पढ़ के बताओ। ZDVRO ZNTZS।
देखिए, इनको निकट दृष्टि की समस्या है, जिसे मायोपिया कहते हैं। और कितने देर बेटा मोबाइल यूज करते हैं आप?
पूरे टाइम फोन में घुसी रहती है, एक भी नहीं सुनती मेरी।
नहीं, देखिए फोन आपको यूज नहीं करना है। अगर पढ़ाई फोन से करनी है तो 20 मिनट पढ़ाई करने के बाद 20 मिनट की दूरी पे 20 सेकंड के लिए एटलीस्ट देखना है, ठीक है, जिससे आंखों को थोड़ा आराम मिल जाना है, ठीक है। और मोबाइल यूज नहीं करना है, ठीक है।
समझ में आया तुम्हें?
A few moments later.
सभी दस्तावेजों के मद्देनजर 20-20-20 रूल को फॉलो करें।
Thank you, team RRR. Very nice message. Dr. Sovita ma'am, would you like to comment anything?
No, quite interesting thing. Only I want to ask, when you make such videos, do you take patient consent?
Ma'am, actually, we just tried. These are our fellows only, our peers. So these are doctors only. We just enacted. They are acting as patients, ma'am. We just wanted to send out the message, ma'am.
Oh, the daughter was quite young then.
Ma'am.
Good.
Thank you, ma'am.
Thank you, ma'am. Dr. Sumita ma'am, would you like to comment anything?
Yeah, kindly excuse, my kid is also in the background. Yeah, so very nice video, but I think you could have covered more points. It was very short, isn't it?
Ma'am, we had a time limit to it.
Okay, okay. Okay, sure. I think you could have covered more points as well, but whatever you did was
Thank you so much, ma'am.
Thank you, ma'am. Thank
I
you.
think I especially like the few moments later wala part. So that's where the parents come and tell ki please go healthy khane ko bolo. So I wonder, I am unable to follow that.
Ma'am, we have Dr. Rahul Shukla. He is the star of the video. He is here. If we could like turn his video on from our team RRR.
Good evening, ma'am.
Also, ma'am, with your permission, we would like request to welcome our mentors, Dr. Madhu ma'am and Dr. Indranil Saha sir.
Yes.
Yes.
Hi, Dr. Madhu ma'am and Dr. Indranil. Yeah. So
Hello.
Hello, ma'am. Hi. Hi.
I'm in the car
Yes, ma'am.
going to airport.
Yeah.
Thank you so much for joining, ma'am.
Yeah. Ma'am, any few words of encouragement from your side to your team, ma'am.
I would always say to this team is that you all are good kids, but develop a thinking mind all the time. Reading, learning, fine, but it's very important that whatever you see, whatever you learn, think about it and develop a kind of paradigm, because that is what is missing these days. These manual, mechanical things, even AI will do for you.
Thank you, ma'am. Thank you for those words of encouragement and for joining. I know that you're busy today. You're multitasking with, conferences with your DOS subspecialty day as well. And thank you so much for
Thinking is
joining.
something nobody will do for you. So I went to airport. So I joined you all.
Thank you, ma'am. Thank you.
Thank you, ma'am.
Thank you, ma'am.
Ma'am, also Dr. Indranil Saha sir, please.
Dr. Indranil, hi.
Thank you. How have they done so far?
They're doing well, ma'am. They're doing well. So, yes.
Great. Thanks.
We'll wait for the results. Yes.
Thanks.
Thank you, ma'am.
Thank you, ma'am.
Dr. Indranil.
Hello, everyone. First of all, congratulations for holding such a fantastic event. I see all the teams performing really exceptionally well. And I hope our team RRR, lives up to the expectations. And as our director, ma'am, CEO, ma'am, and Professor Madhu, ma'am said, it's always to aim for a holistic development and just not be a bookworm. So that's what our motto is. And once again, congratulations and all the best. Thank you.
Thank you, sir.
Thank you, Dr. Indranil, for joining and giving those words of encouragement. With this, over to you, Dr. Harshal and Dr. Maushmi.
Heading to last video of the round, Team 5, Endless of Hope.
Round 1, fight!
Are you also facing this problem at home? Is your child also addicted to screens?
Strong vision starts with smart habits. Now, let's see how we can improve eye health in our children. Children should have adequate sleep time of around 8 hours. Encourage going to bed and waking up at same time every day. Decrease screen time and near work duration to around 1 hour per day. The screen should be held at eye level with a recommended distance of 50 to 70 cm from the eye. Have a screen time curfew of 1 hour prior to bedtime. Children should have at least 2 hours of outdoor activity. Encourage them to play outside and please make sure it is less screen and more green. Try to increase more vitamin A, C, E and antioxidant-rich food like green leafy vegetables, carrots, citrus fruits, nuts and seeds to your child's diet. Avoid rubbing of eyes, as vigorous rubbing can cause corneal damage, increased chance of infection, astigmatism, worsen existing conditions like allergies and dry eye. So, let's ensure that our kids have clearer vision into the future.
Thank you, Team Annulus of Wind. It was an excellent presentation, and that word scrambling, whatever that you did, it was excellent. Very good. Congratulations. Ma'am, Dr. Kavita, ma'am, you want to comment anything?
Yeah, nice video. All the videos are nice actually. All of them have done very good hard work. Nice videos.
Dr. Prachi, ma'am?
Yeah, same comment. Excellent video.
Dr. Sumita ma'am.
Excellent video. I think the creativity was simply beautiful. It was simple but extremely creative and beautiful. I really loved it. Thank you.
Thank you, ma'am.
Dr. Sovita ma'am.
Yeah, it was too good. It was, I mean, picturesque for the normal audience also, and it conveyed the scientific information also at the same time.
Thank you so much, ma'am. With this, we
Snatching
concluded
the
the round.
iPad, I think I could picture me and my daughter doing it, you know. Actually, this is how the scene is at home, you know. We are snatching iPads from each other. So, yeah. So with this,
For that, I would like to add a comment. First, we have to stop using the thing, then the kids will stop.
Yes, ma'am. I
So
agree.
that doesn't happen. Everybody is on the phone nowadays.
True, ma'am. True. Yes. So, with this, we come to the end of the first two rounds. I would request our judges to, you know, just mark, just a second. Could you just go behind Roshni? Yeah. So I would request our judges to mark the Excel sheet and just send the filled Excel sheet on Dr. Harshal's or Dr. Maushmi's personal message. And we'll be continuing with the other two rounds of quiz and the jumble words. And our judges, you're more than welcome to stay back, but we know we have taken off enough of your time for your busy schedule. So a heartfelt gratitude to all the judges, Dr. Kavita ma'am, Dr. Prachi, Dr. Sumita, Dr. Sovita, for being with us wholeheartedly. All those pointers, minute clinical pointers, the questions that you asked them, they were so helpful not only to the participants but also to all the audience that are watching today's program and will watch on the YouTube. Thank you so much. A heartfelt thanks to each of you. And I would also request each of you to give one or two some closing comment on what was your experience, any feedback that you may have. So we can start with Dr. Kavita ma'am.
It was very nice, especially listening to PGs. So it's really nice. So they are all learned PGs. Oh, okay, that's the comment. All the one sitting out there they were just learned.
Thank you, ma'am. Dr. Prachi ma'am, what was your?
I would like to congratulate you on this initiative. Very, very nice theme, very nice concept. And congratulations to the residents. I mean, in this first year, I'm sure I wasn't so well read when I was at your level. So hats off to you guys. You are doing really well. Just continue reading, continue growing, and best wishes to all.
Dr. Sumita, your thoughts?
Yeah, I think excellent organization, and I'm sure a lot of effort has gone into organizing this. Congratulations to all the moderators and the YOSI team and everyone involved. That's one thing, and the other thing is, I mean, it's a very good initiative because all through we always concentrate on academics, and when people come out as clinicians, they have to be a whole individual, addressing patients, talking to them, and also being creative in promoting themselves. So this really promotes them being a complete individual and a complete doctor as such, and I really congratulate you on this initiative.
Thank
you. I think those initiative taken by the PGs and residents will be helpful for the practicing doctors, right? They really have done very good videos, very good ones.
Thank you, Dr. Sumita, Dr. Kavita ma'am. Dr. Sovita, your thoughts and what did you feel about the whole session?
Yeah, first of all, I would like to congratulate the organizers, all of you, to creating such a platform. And for the residents, I would congratulate them because they have got the courage to present live and also to prepare so well as a comprehensive approach for the entire topic, not only as the theory part, but also to bring in their creativity to it so that it makes simpler for everybody to understand and also implement practically. Well done. Congratulations to all of you, and thank you for inviting us.
Thank you, judges. We just have a small token of appreciation from YOSI. We have these certificates that we've prepared, and we'll be sharing this on the WhatsApp group as well. So thank you, Dr. Prachi ma'am, for joining us today, and Dr. Kavita ma'am for sharing your insights and all the small pointers. Dr. Sumita. For that wonderful, your wholehearted participation and being with us throughout. Dr. Sovita, once again, thank you so much. And we can stop sharing. And before we move on to the next one, we'd also request, can you stop sharing, Moshmi? Yeah. I'll request everybody to just quickly switch on their video. We'll have a quick screenshot with all our judges to make this moment, memorable for all of us. And I'll request Mr. Sai or Manjula, if you can take a screenshot for us. Mr. Sai, are you there?
Yeah, I am here.
Yeah. So if we can just request everybody who's there, in the meeting to quickly switch on their videos. And at the count of 3, we can do the yo sign, and we can all.
Okay.
Yes.
Hats off to Yosi or welcome Yosi or what you want. Grow up. Huh?
Yes, ma'am.
So very nicely done. You have done it very nicely. It was a nice thing.
Can we quickly?
I thank Sai also for all the help he's giving to everybody nationwide. So thank you, Sai and Manjula.
Most welcome, doctor.
So we can just, so you can take 1, 2, 3.
Done.
Thank you, Sisa. So once again, thank you so much to all the judges, and you can just send the Excel sheet. If you missed out on any presentation, I've shared the YouTube link on the group. You can just go back and review the presentation and mark them.
Yeah. Thank you.
Thank you so much, ma'ams. Yes.
Thank you. Excellent work. Thank you very much.
So over to you, Dr. Harshal, for the next 2 rounds. Yes.
Yes, ma'am. Thank you, ma'am. So after such nice creativity which you guys have shown, so let's now test your knowledge. So we are coming to our round 3, the quiz round. So here one pre-decided team member will attempt this round. It will consist of 10 questions, which will be encompassing multi-speciality. We'll project the question as a PowerPoint slide, and we'll give 20 seconds to all the teams to respond in the chat box. You will have to write team number 1, 2, 3 subsequently. And whoever types their team letter first will be asked to unmute and give the answer. So there will be +1 for correct answer, but remember there will be a -2 for no answer or incorrect answer. Another important thing is before we display the quiz, please don't write your team number, else you will be losing out on marks. Okay. And there will also be 3 audience.
We'll be writing XXX after every question, so they have to wait for that to come. Also, one more thing, all the teams just check, and only one device can be used. Okay, you can play with only one device. If we see there are 2 devices, you are immediately disqualified from this round. Also, just make sure that in your chat settings it's mentioned to everyone. Otherwise, you will not be able to see your response.
Right.
Just make sure that. Yeah, over to you, Mashmi. Sorry for
So there will be also 3 audience questions. So we hope that audiences will also get involved in this round. And you have to attempt, they have to just type I in the chat box and we'll ask them. Okay. So all the best to all the teams. So Dr. Harshal, will you look after the chat box?
Yes, ma'am. Ma'am, the timer 2 minutes, like
20 seconds.
20 seconds.
Yeah.
Ma'am, I have a doubt. Can I ask a doubt?
Yeah.
So after typing the team number in the chat box, and if you don't answer only, you get the -2, right? If you don't attempt the question at all,
then also -2. So think carefully before you type in the chat box.
Like without
If you know
typing,
the answer, even if you don't answer, then also it's a -2.
if we don't answer at all, also.
Yes, because what we've realized from the previous sessions was that the questions were getting wasted. People just wanted to just answer not before even reading the question. So we want to avoid that,
No, ma'am. If we didn't type the question, type the number, and if we skip the question, we won't get negative, right, ma'am?
No. If you type the number and then, then you have to answer.
Okay, got it.
It's only valid if you type the number.
So let's have a trial round first so that you guys are accustomed to what we are going to do. So this is a trial question. Where is Taj Mahal located? So if you know the answer, write in the chat box and we'll ask.
Okay, so we have team 1 macular goals. So you can just unmute.
Ma'am, am I audible?
Yes.
Agra.
Yeah. So
Okay.
that's how it will be. Is it clear for everybody now? So Maushmi, just wait when I tell you to, then you move on to the next question. Okay?
Right.
Yeah, now you move on, Maushmi, to the next question.
So now we are starting with the main questions. Okay. So this is our first question. The muscle of Riolan is a smooth muscle, is the most anteriorly placed orbicularis oculi along the eyelid margin, contracts during blinking and shortens the canaliculi and does not represent the gray lines in clinically.
So we have a chat box typed by Dr. Rahul Shukla from team RRR. Dr. Rahul, please unmute yourself. Otherwise, you get a -2. And you have to answer within 10 seconds. I'll not give you more than that.
Bus is entirely a B option, ma'am.
Okay, let's see the answer.
So the answer is C.
So it's a rock. So they get a -2 for this. Yeah. Maushmi, just wait. Yeah.
भाई नहीं ऐसे तुरंत मत दबाओ तुरंत ना दबाओ ये सर्च करें क्योंकि वैसा वाला है ना
Can
रुक
you
जाए।
unmute yourselves? Yeah.
Please mute yourself.
Yeah.
So
Go on,
this-
Maushmi. Next question, please.
A 65-year-old woman is examined as part of a routine annual checkup. On retroillumination of the cornea, flake-like deposits in the deep corneal stroma are detectable centrally. Visual acuity is normal and there are no other ocular findings. The most likely diagnosis is Hassel-Henle bodies, cornea guttae, cornea farinata, central cloud dystrophy.
So team 2 Eye Avengers has typed. You can just unmute yourselves.
Ma'am, is it car C option, ma'am?
Okay, so you're going with C?
C, yes, ma'am.
Yeah, absolutely correct. It's C.
So this is team Eye Avengers, right?
Yes, ma'am. Team 2, ma'am.
Yeah. So just wait. I'll just move on. Yeah, Maushmi, you can move on to the next question.
So now there's an audience questions. So please, team members, you don't type here. So audience questions, which disorder is more common in males? Mutes, uveal effusion syndrome, APMPPE, and birdshot chorioretinopathy.
Anybody besides the team members in the audience wants to answer. You don't have a negative marking. You just have a shot to win a prize. So you can type if you can type an I. So Dr. Varsha, yeah, can you unmute yourself? Yeah.
Ma'am, is it D, birdshot chorioretinopathy?
Can you get the answer?
Yeah, so the answer is uveal effusion syndrome. Birdshot is more common in myopic females. Yeah. Okay.
Right, ma'am.
Yeah.
So
1 second.
Yeah.
Yes. Go on, Maushmi. Yeah.
So now the question number 3 for the teams. All of the following are more common in normal tension glaucoma than primary open angle glaucoma, except migraine, paraproteinemia, Raynaud's, and systemic hypertension.
So team Eye Avengers are the first to type. Please unmute yourself. Team 2.
Ma'am, option D, ma'am, systemic hypertension.
Can we move on to the answer?
You are absolutely correct. It's systemic hypertension.
So you get a +1 for this. Yeah. Okay, Maushmi, we can move on to the next question, please.
So a corneal infiltrate is suspicious for fungal keratitis. Which laboratory test would be least helpful in aiding the diagnosis? Lauenstein-Jensen agar, calcofluor white stain, culture on Saburat agar, or GM sustain?
So team 2 has again typed. So team 2, quickly unmute yourself.
Ma'am, LJ agar, ma'am, A.
Can we have the answer? Yes.
You are correct. Good.
Yes. Maushmi, move on to the next question.
So question number 5, when a patient complaining of headache and transient visual obscuration, whose examination reveals bilateral disc edema, the first diagnostic intervention to be taken is lumbar puncture, measurement of sedimentation rate, CT scan, or measurement of blood pressure.
So we have team 2 Eye Avengers again typing first. So team Eye Avengers, can you just unmute yourself? Yeah.
Ma'am, is it CT scan, option number 3?
Can you have the answer?
First, you have to look the blood pressure.
Okay.
So we get a -2 here. Okay.
Ma'am, may I please comment something?
Yeah.
Ma'am, aren't we supposed to not type after the question is read out completely?
No, that's okay. That's okay. That's fine. That's fine. Yeah. 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 Maushmi, can move on to the next question.
So question number 6, a patient presents with follicular conjunctivitis and a cluster of umbilicated papules are noted near the eyelashes of the left eye. The most effective treatment for this condition is acyclovir, antibiotics, cryotherapy, radiation.
Team Avengers again.
Ma'am, acyclovir.
Okay.
We have the answer.
So the most effective treatment is cryotherapy.
So Team Avengers, you guys were doing well. Okay, so the reason for negative marking is that you read the question carefully, and as Dr. Rahul, I think Dr. Ravish pointed out, that you guys are actually, typing before the question is projected. So we already lost 4 marks. Okay, you had a +3 and you got 4 minus. So you're in negative. So be careful before you actually.
Okay, ma'am. Okay, thank you,
Dr.
ma'am.
Harshal, can you just take over the chat box for a minute? I'll just
Yeah, ma'am.
come up. Yeah. So Maushmi, move on.
So now there's an audience question. So the most common cause of posterior uveitis is sarcoidosis, syphilis, CMV, toxoplasmosis. I think this is one of the easiest questions. So we are hoping lots of people participate to answer this question. Dr. Harshal, do we have any audience?
No, ma'am.
I think Dr. Noor Nisha has typed.
Dr. Varsha.
Yeah, Dr.
Dr.
Varsha.
Noor Nisha, I
Ma'am,
think,
it
wants
is
to type
Toxo.
the answer.
Okay.
So, yeah, we'll give a chance to Dr. Noor Nisha. Yeah.
Same me, ma'am.
Can we have the answer?
So the answer is toxoplasmosis.
Okay.
Yeah.
Yeah.
Okay.
Just a second. Yes, Maushmi, go ahead.
The next question. Yeah. Question number 7 for the teams. All of the following are features of Aicardi syndrome except X-linked recessive inheritance, agenesis of the corpus callosum, lacunar chorioretinal degeneration, or severe mental retardation.
Team Avengers again. You have to
X-linked recessive, ma'am. Option A.
Can we have the answer? Yeah.
You are absolutely correct. It's X-linked recessive inheritance.
Okay. Yeah. Next question, Maushmi.
Okay. So you see a picture here and where it's written brolucizumab, right? So the recommended dose of the drug for intravitreal use is, there are 4 options. Just look at it carefully. 6 milligram per 0.1 ml, 0.6 milligram per 0.05 ml, 6 milligram per 0.05 ml, or 6 microgram per 0.5 ml.
So Dr. Rahul from Team RRR, you can unmute yourself.
The option, ma'am. 6 milligram in 0.05 ml, ma'am.
Okay, C. That's what you're saying, right? Yeah. Can we have a look at the answer?
You are absolutely correct.
Okay. Okay. 1 second. Let me type XXX. Yeah. Yeah, Maushmi, you can project the next question, please.
So question number 9, the approximate age of onset for accommodative esotropia is closest to 1 year old, 3 years old, 5 years old, or 7 years old.
So Team RRR, Dr. Rahul, you can just unmute yourself.
Ma'am, 1 year. Option number A.
Okay.
You get a -2 here. Okay. Yeah. So can we have the next question, Dr. Maushmi?
So now there's a third audience question. An Amsler grade held at 33 centimeter measures approximately how many degrees of central vision? 5 degree, 10 degree, 20, or is it 30 degree?
So anyone from the audience, if you want to attempt, you can type an I and we can ask you to unmute. So Dr. Noor Nisha has again this thing. So just unmute and give the answer. Don't cheat. Don't give the answer, Maushmi, right now. Yeah, Dr. Noor Nisha can unmute and give your answer. Dr. Noor Nisha, we couldn't hear you. Can you unmute yourself and give the answer?
20 degrees, ma'am.
Sorry?
20 degrees, ma'am.
20 degrees. Okay. And Dr. Varsha, what is your answer?
10 degree, central 10 degree.
So let's see if who's correct or neither is correct. Yeah.
So the answer is 10 degree. I think Dr. Varsha gets.
Dr. Varsha gets it. Yeah. Okay. Yeah. So let me type XXX. Yeah, can move on to the next question.
So this is the last question. What is the histology of most primary CNS lymphoma? Is it Hodgkin's T lymphocyte lymphoma, Hodgkin's B lymphocyte lymphoma, non-Hodgkin B lymphocyte lymphoma, or is it non-Hodgkin's T lymphocyte lymphoma?
So Dr. Rahul from Team RRR again.
Option B is correct, ma'am. Hodgkin's B lymphocytic lymphoma, ma'am.
Which option? A, B, C, D? Which one are you saying?
Option B, ma'am.
B. Okay. Can we have the answer? Okay. So get a -2 here again. Yeah. Okay. So let me just correct. So I Avengers have got a 3, 4. So I Avengers has got a 0 here, and Team RRR has got a -5. Okay, in this round. Yeah. So over to you, Dr. Harshal.
Yes, ma'am. Coming to round 4, the rules are the wordsmith word, that is unscramble, and the rules are one pre-decided team member will play the round, and 6 jumbled one will flash on the screen, and time to solve that jumbled word is 1 minute, and one mark for each correct answer. For example, the trial round is like you can see there are 6 jumbled words, and in the next slide you have to identify as much as possible within 1 minute.
Dr. Harshal, we can allow one of them to try this
Okay.
so they have an
Yeah.
idea.
Any one of you want to try and this trial round?
Ma'am,
Yeah.
these are fruits like apple. First one is apple, second one is orange,
Yes.
third is banana, fourth is
Yeah.
mango, fifth strawberry, and sixth is pineapple.
Very good, Team Gold, Team McClure Gold. Yeah. We'll start with Team 1, McClure Gold. There will be only 1 minute. Yeah, ma'am, I'm starting time.
Yeah.
Let me know when I start.
Yes.
Yeah.
1 minute.
What is he doing?
Sorry. Yeah. You can start, ma'am.
McClure goes, your time is on.
Okay, ma'am. Ice speculum. Fourth one is ice speculum.
Okay, you carry on. We'll see it later.
Third one is amphotericin B, ma'am.
Okay, you have
Okay,
attempted to. Ten seconds remaining. Yes, the time is up.
I have answered actually one only. The fourth one, eye speculum. The third one was ophthalmic probe. Next.
Okay.
We'll get only 1 point, 1 mark.
So these were the answers: endoscopic laser, cryoplexy, ophthalmic probe, eye speculum, retinal forceps, and vitreous cut. Yeah.
Okay.
Coming to Team 2.
Sir,
Avengers, are you ready?
Yes, sir, we are ready, sir.
Yeah, let me start.
Shall I start?
Yeah, ma'am, you can start.
Okay.
Diathermy, sir, first one.
Yeah, correct. Next.
Conjunctival forceps, third one.
Yeah. Next.
Corneal scissor, sir, fifth one.
Yeah, correct.
Irrigating
Next.
cannula, sixth one.
Good, very good. Last.
Clamp. Calesian clamp.
Yeah, very good, very good.
Yes, sir.
One
Team
remaining.
Avengers.
Lacrimal probe, sir.
Yes,
Very good.
very good.
So I think they have attempted all, right, Dr. Harshal?
Yeah, ma'am, they have attempted all, and they are all
And
correct.
all of them are correct. Yeah.
Yes.
Fantastic. Yeah. Thank you.
Team 3, Optic Avengers, are you ready?
Team Optic
Team
Avengers.
Yes, ma'am.
Yeah, you can just, we'll request you to, switch on your camera.
Unmute. Yeah.
Yeah.
Okay, ma'am, you can.
Yeah.
You can attempt any one, don't have to go in the chronological order. And there are no negative marks in this round.
First, is it a biography map? Fourth, keratography. Anterior chamber, sixth.
Okay.
Catalase injection, fifth.
Okay, so your time is like you have answered keratography and anterior chamber. The first one you have whatever you said it's wrong. So first one was mammography, angiography, second one biomyoscopy and keratography, and the fifth one topical anesthetic, and the sixth one is anterior chamber. So you have corrected 2. Team 4, RRR. Are you guys ready?
Yes, sir.
Okay. Ma'am, you can start.
Team RRR, please switch on your camera.
Ma'am, first is axial length.
Okay.
Second, rate. Retinal tear, second.
Very good. Next.
As ma'am told, you can try any of them. It's not important that you go in a
Third
chronological.
is syndrome. Fourth is some syndrome. We have toxic neuropathy.
Yeah, good. Okay, the time is up. You have given first is axial length, right? Retinal tear. Second one is right. And the last one, toxic neuropathy. The third one was congenital glaucoma. Fourth one is photic knee syndrome, and the fifth one is epithelial ingrowth. So you have given 3 answers correct.
We can give them a 0.5 for the syndrome.
Okay.
At least I guess, because it is 3 words, we can give them that. Yeah, we can give 0.5. Yes.
3.5.
Yes.
Very good. Team RRR. Next team 5, annulus of wind. Are you guys ready?
Yes, ma'am.
Please switch on your video. Yeah. Ma'am, you can start.
LASIK. Third one. Press by LASIK.
Okay.
Sixth one is
Intex.
Okay.
Fifth is LASIK.
LASIK.
Okay. Okay.
Cross-linking. Corneal cross-linking.
Collagen.
No, corneal cross-linking. And
No, second one is collagen cross-linking.
collagen cross-linking.
Okay.
Retinopathy.
First one is retinopathy.
Have you answered all 6? Retinopathy, collagen cross-linking, LASIK, press by LASIK, LASIK, Intex.
Very good. Very good. You have corrected all. You have given all correct answers. Yeah. Very congratulations. With this, we have finished all the rounds.
Yeah, Dr. Harshal, please do continue.
Yeah, ma'am. You guys has thank you so much, everyone. All the participants, you have done very good. Thank you so much for giving us time, and we know you have from your all schedule, you have from your thesis and all, you have just given us time. It's a wonderful session with you all, and not only you have learned, we also have learned all from the great mentors and all. Thank you so much once again. Thank you so much once again. And as a token of respect, we are giving you like these certificates, like Dr. Smiti Soni Tambi, Dr. Arvind Krishna VP, Dr. Priyanka K, Dr. Saundarya P, Dr. Karishma P. Reddy, Dr. Mansa B. Piata, Dr. Shubham Agrawal, Dr. Medha Rai, Dr. Akash Deep Karthik, Dr. Ravish Bindal, Dr. Anubhuti Bhargava, Dr. Rahul Shukla, Dr. Hiba Abdul Rauf, Dr. Haifa Abdul Jalil, and Dr. Shruti Ji. Thank you so much, everyone, for giving us your time. This is a wonderful session. We will like you to see in our second conference in Delhi. You are all invited. Please do come and enjoy. Yeah. Over to you, ma'am.
Yes, ma'am. Nupur ma'am, you want to share something
Yeah,
before we?
so I would like to congratulate all the participants here. I think it takes a lot of efforts, as the judges have mentioned, to come up and present on this podium. Some of you were getting last minute jitters, I think, but we pulled you up. Okay, we did not let you go. So I think whoever wins, it's the efforts that matters the most. And trust me, the efforts that you all made today, all of you were, yeah, Kavita ma'am, yes. You want to say something?
No. I'm just listening.
Yes, yes. So I think the efforts that all the five teams that made today were truly, truly tremendous, right from your presentations to answering the questions to, to your creative reels. Really, really a great job by all of you. And we look forward, as Dr. Harshal mentioned, we have our second annual YOSICon, 5th to 7th September at India Habitat Center in New Delhi. We welcome you all there. We welcome, we'll request our judges also, Dr. Kavita, Dr. Prachi, Dr. Sovita, Dr. Sumita. We look forward to having you all also in our physical session at the India Habitat Center. And bless us there. Also, that the abstract submissions are open. If any of you wants to submit any free paper or case presentation, it's a wonderful opportunity. And I would like to thank the entire YOSI Governing Council. Having an activity for residents was actually Dr. Divakan Misra's idea. We just put it to execution. The logo has been very beautifully crafted by our secretary, Dr. Nilesh. And the iROCK team, especially, the whole team, what you're seeing the today's session is just a glimpse of it. The whole team, we have a 15-member team. We've been working since the last, I think, 2-3 months. We've made all the questions. There was a team who made all the jumble words, seminar presentations. Excellent teamwork by the entire iROCK team. And I would like to also thank today's moderators, Dr. Maushmi, Dr. Harshal, for doing a phenomenal job with the organizing. And it was so seamless and so smooth. So proud of you. Thank you so much. And to all the participants, once again, you are the heart and soul of iROCK, and you are right now in your residency state. The whole YOSI platform is meant for you guys. We want you all to come up and, and you're the future leaders of YOSI and, the Indian ophthalmology. Do utilize this YOSI platform to the maximum. It has lots and lots to offer, not just academics, but so much of camaraderie and so much of friendships and, so much. You just have to explore this platform to its best. And we are there to guide you and help you in any which way that you want. So
Ma'am,
thank you so much.
just to add a word, ma'am. Thank you very much, ma'am. This has been a new platform for us, especially a topic for us. It's nystagmus, which we would not even think of talking about when it would just be another final year examination. So we have explored. At the beginning, we were not sure whether it fits into pediatrics or neurophthal also. So it was, and all of you were very helpful throughout the thing. Every time you were patient with us on all the late submissions. And thank you very much, ma'am. This actually is a platform where it's like a thing we need to be doing, but we still push ourselves to do better. Thank you very much again, ma'am. Thank you so much. Thank you, sir.
Thank
Thank you, Dr. Karishma. That video was actually very good, your presentation. Like we have seen every nystagmus video in a stretch. So actually, I haven't seen in my life in a stretch. Thank you so much for
we
giving for
the mentors, it was their work, and we were just grateful because of this. We present for this presentation, we just got to get everything like this in a small thing, and we learned so much from this, sir. Like how do now I just felt there is something more beyond ice where we can go explore also through the ice. So
good.
thank you very much, sir. Thank you.
Thank you. Thank you so much.
I would request all of you to encourage your other resident friends also to explore this platform. We've already opened up the registrations. So, if you can just, if you feel it was useful for you, you can just spread the word and ask your other friends also to register for it. So, yeah, I think Dr. Kavita ma'am wanted to say something. Ma'am, you want to?
In the end, I would like to thank everyone for such a wonderful session, and especially YOSI iROCK. I think you should give the title YOSI Rock On. It is, or it has to be we. It is not just I. So I think Rock On is very good. It would be very good, and I share my blessings to all you YOSI guys. All the best.
Thank you, ma'am. Your blessings mean a lot to us. So I know Maushmi told me you had a busy schedule and you actually adjusted your OT timings.
No, I just finished my OT at 2 and I came home and I just, yeah.
Yeah, you've not. Thank you so much, ma'am. On a, Sunday afternoon, and it means a lot to us, ma'am. It's very encouraging to have seniors like you join and share insights, especially with the residents. Means a lot. Thank you so much, ma'am.
Thank you. Thank you.
Thank you. We can just stop the live streaming, Mr. Sai. And I would like to also, as ma'am had mentioned, extend a huge thank you to Mr.